Very good morning to everyone. Welcome to the CPC from the Department of O&G. Today, we are going to talk on the topic of preeclampsia in seronegative antiphospholipid syndrome, a battle never won. With us today, we have 4 speakers. We will start off with Dr. Naazirah, followed by Professor Dr. Mohd Shahrir, then followed by Prof. Dr. Tan Kiok Chin, and then it will be summed up by Dr. Izyan Atiqah. So without further delay, I would invite Dr. Naazirah to start off with the case presentation.
Thank you, Prof. Lin. I would like to share my screen. All right. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning. So I'll be presenting on a case in regards to the topic of discussion today. So my patient is Madam Siti. She's 39 years old, Gravida 3, Para 1 plus 1, currently at 32 weeks, 5 days period of gestation. She has one previous LSCS for severe preeclampsia complicated with HELLP syndrome at 31 weeks, GDM on diet control, likely seronegative APLS with history of indeterminate APH at 23 weeks. So presenting on the focus history, she's married in 2019, not known to have hypertension pre-pregnancy. Her first pregnancy was in March 2020, in which she was diagnosed with gestational hypertension at 29 weeks, which does not require any antihypertensive. But during her blood pressure monitoring, it was uncontrolled and required admission at 31 weeks, in which then she developed severe preeclampsia with early onset IGR and as well as HELLP syndrome, requiring emergency LSCS. She delivered a baby boy, 1.1 kg, requiring admission to NICU for 49 days. She was on labetalol 200 mg TDS upon discharge, which was then stopped 2 weeks postpartum, and she remained normotensive. Her placental HPE, which shows maternal vessels displaying fibrinoid necrosis consistent with hypertensive changes, which we will discuss later on. There was no APLS screening done. Implanon was inserted in August 2020, which was then removed in June 2022. During her second pregnancy, it ended with spontaneous miscarriage. It was initially a viable pregnancy, then there was an absent fetal heart. She was just about to start TAP aspirin at that pregnancy. And in May 2023, we had done an APLS screening, which was negative. We also proceeded with connective tissue disease screening. ANA was positive, 1 in 320 speckled pattern. However, her anti-double-stranded DNA was negative. Her C3, C4 was raised, 153 and 70 mg per deciliter respectively. However, there's no other CTD symptoms. During her third pregnancy in June 2023, her booking parameters, her weight is her BMI is 24.4, which is normal. Her blood pressure was 130 by 80, which is normal. She was not proteinuric or glycosuric. And she was started very early on aspirin, 150 mg OD, as well as later on started on calcium, 1.5 gram OD. An NT-scan was done, which is low risk. She was seen by our rheumatologists in our combined clinic at 15 weeks, in which she was given the impression of most likely seronegative APLS with the obstetric criteria of IGR with severe PE at 31 weeks, as well as miscarriage. At 17 weeks, she was diagnosed with GDM on diet control with the MOGT of 4.8 and 7.9 with the normal HbA1c and normal blood sugar monitoring. However, at 23 weeks, she was admitted in view of antepartum hemorrhage. She was investigated and remains normotensive. A detailed scan showed a single echogenic foci with growth at 10 centile with normal liqua and anterior low-lying placenta. So we had also used this opportunity to do a uterine artery Doppler. As we know, she's at risk of developing preeclampsia this current pregnancy. So this is the uterine artery-Doppler, which is done bilaterally, right and left, which shows notching. Just for context purpose, if you can see on the red colored Doppler waveform is usually the normal uterine artery Doppler. However, on the right side, as you can see, there's notching. This suggests that the placenta have not developed properly, thus may result in increased resistance to the blood flow. So, fortunately, we have seen her last week at 31 weeks. She remained normotensive and non-proteinuric. Her pre-eclampsia profile was normal. Her uric acid was 247 with a normal liver function as well as renal function. Her fetal growth is between 10 to 50 centile with normal liquor and with the latest estimated fetal weight of 1.6 kg. So, I thank all of you for listening the case.
Okay, may I invite Prof. Shahrir to continue with the presentation with regards to antiphospholipid syndrome in our difficult situation?
Okay, thank you, Prof. Lim. I'll share my slides. Okay, thank you. First and foremost, Bismillahirrahmanirrahim. Alhamdulillahi Rabbil Alamin. Wassalatu wassalam ashrafi al-anbiya wa mursalin wa ala alihi wa sahbihi ajma'in. Allahumma salli ala Sayyidina Muhammad wa ala ali Sayyidina Muhammad. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Rabbi yassir wa la tu'assir, Rabbi tammim bil khair. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to all. Thank you. I would like to thank O&G for inviting me to have this short session on antiphospholipid antibody syndrome, and later on we'll talk a bit about seronegative antiphospholipid antibody syndrome. Okay, so let us start off by the normal variant of all these clinical presentation, which is your antiphospholipid antibodies. As you can see, we have more than 3 antibodies which is related to antiphospholipid, which includes from phosphatidylethaноlamine all the way to annexin A5. Now, we don't screen this probably because of the clinical relevance as well. But then we should, if we have negative of your usual anticardiolipins, anti-beta-2, glycoprotein I, and lupus anticoagulant. Now, just to remind everyone, the most thrombotic of the 3 is lupus anticoagulant, followed by anticardiolipin IgG, and finally anti-beta-2 glycoprotein I. Surprisingly, anti-beta-2 glycoprotein I is the least prothrombotic in these 3 antibody, although it is the main pathophysiology of the molecular is actually anti-beta-2 glycoprotein 1. So this is a very complicated process of antiphospholipid, whereby the first hit, we start off with the third box on my right, whereby the first hit will mean that the antibody develops, changes the morphology of the 3 proteins, and then started to promote non-atherosclerotic vascular stenosis. And this is the first hit of the 2-hit theory involving antiphospholipid syndrome. And then when we start on the left going back, so you can imagine that the process starts in the middle and then restarts at the left. So it's like a vicious cycle, turning and turning. And as a result, the stenosis worsens and thrombosis happen. As you can see from upregulation of beta-2 glycoprotein 1, second hit, and then that's where the inflammation starts, and so on and so forth. Coagulation will be promoted, and prothrombotic happens. So this is a rough picture, and you can actually have a more concise explanation in a cardiology journal. This is the 2023 new classification of antiphospholipid syndrome, whereby now it is more of given weight and therefore scores, and you have to there is an entry criteria on the top, and followed by clinical manifestations, and also laboratory domains. So you have to have either macrovascular, macrovascular venous thromboembolism as the first D1. D2 is macrovascular arterial thrombosis, followed by D3 microvascular and D4 obstetrics. In this means that the male patients will not be underdiagnosed in a way, because we will be looking for especially young thrombotic events, young strokes, young MIs. We have to look at this antiphospholipid syndrome very closely so that we don't miss anything of that sort in the male. Because in the female, the obstetrics part is easier seen, and therefore they are more noticed in clinical sense. So again, right now, a lot of pathologists. Can everybody mute their mic? Okay, so the thing about the serology of laboratory is that it has to be repeated 12 weeks apart, and many of the patients are either pregnant, already on heparin, already on warfarin, already on NOAC, and this gives rise to proper interpretation and doing the antiphospholipid screening, especially after 12 weeks when the patient has already been treated for a thrombotic event, and the thrombosis, we can never stop treatment until the end. So in that sense, that's the difficult part of diagnosing using the laboratory domains and criteria. And for this matter in 2023, it is already recognized that if you do a repeated investigation of these antibodies within 3 years, then it is significant that we can say that it is positive in that sense. But then again, it is still under investigation and under debate by various hematologists, pathologists, and rheumatologists for that event. But making the antibodies difficult to get a full diagnosis in this instance. So seronegative antiphospholipid, well, there's only a few articles mentioning that, but one such important one was done 2022, involving some hundreds of patients actually, and they are looking at a multi-center study, but unfortunately retrospectively. So it is defined in this journal as seronegative, defined as the presence of antiphospholipid criteria manifestations negative, the conventional antiphospholipid antibodies, and coexistence of antiphospholipid criteria manifestation. And these are non-criteria manifestation of APS, which is quite common with the usual antiphospholipid syndrome involving major obstetrics and minor. As you can see, there are cutaneous manifestation like livedo reticularis, livedoid vasculopathy, which is not touched upon by the main positive antiphospholipid syndrome. And then even in the minor, it is considered hemolytic anemia is one of them, Coombs test is one of them, Raynaud's phenomenon. So unfortunately, this article is only one, and we have to really repeat that in various studies to make it a possible criteria for diagnosis of seronegative antiphospholipid syndrome. And in fact, some experts that I've heard before do not believe of existence of this type of criteria, but of course, you can't deny the obstetrics significance and importance in that sense. So this busy slide I am going to unapologetic for this because it's very, very important, whereby they compare between control group, single positive antiphospholipid, and seronegative antiphospholipid. And if you scrutinize proper, this is from the same journal. Just read at your own leisure later on. We go straight to treatment. As you can see, it is dependent a lot on indefinite vitamin K antagonists, your warfarins and your heparin, and also to some extent antiplatelet therapy and hydroxychloroquine. So in short, the outcome display that seronegative antiphospholipid display more thrombosis recurrence, Unfortunately, indefinite anticoagulation and vitamin K antagonist use then controls without non-criteria manifestation, and the presence of such features in patients with thrombosis and negative antiphospholipid negatively impact their clinical course. So it sounds very very ominous and suggests poor prognosis in that sense. So it is recommended that investigate routinely if antiphospholipid is suspected. Seronegative antiphospholipid syndrome early detection is unfortunately unavailable. As you can see, we do not screen for other antibodies, as I mentioned just now, and very much dependent on obstetrics. And management guidelines are limited for seronegative antiphospholipid syndrome, and the management needed to be multidisciplinary in that sense. Right, so that's all from me. Thanks. You're muted, Prof. Lim.
Muted. Okay. Thank you, Shahrir. So from the clinical presentation by Dr. Naazirah, we know that this patient has very early preeclampsia since about 26 weeks. And when we screen, there is a very possibility that we have to think of antiphospholipid in her because of this, yeah. So so what is happening in the fetus that we are going to listen to Prof. Tan's presentation, whether the placenta is being affected and how placenta HPE can help us in diagnosing whether this patient is having an antiphospholipid syndrome or not, other than our serum markers or those kind of things. Prof. Tan, please.
Okay, thank you very much, Prof. Lim. Let me share screen. So good morning, everyone. First of all, I would like to thank the O&G departments for inviting pathology to be involved in this CPC. Sorry. So this is Madam SS, and this is the history that was given to us in the request form for the HPE examinations of the placenta. And this is a 35 years old woman at para 1, 32 weeks of gestations. She is known to be short stature with a history of severe preeclampsia with HELLP syndromes and GBS positive, post-emergency LSCS, and the birth weight is 1.1 kg. Part of this has been informed. And grossly, the placenta is received a part of the placenta only, not the entire placenta. It is 6.4 by 4.2 by 2.1 centimeter. The maternal surface based on that part of the placenta is complete. There's no retroplacental hematomas. The fetal surface has no amnion nodosum. I can talk about amnion nodosum in later if there is any features that relate to amnion nodosum. It is a very huge topic by itself. Serial sections of the placenta shows unremarkable parenchymal surface. Umbilical cord was not included for assessment. So umbilical cord is actually quite an important part of the placenta examinations. There is some cord accidents that might be missed if that is not submitted. So next we go on to the microscopic examinations. So first, I just want to show you, this is the fetal membrane. And the different part of fetal membrane is that we have amnion, chorion, and the decidual capsularis. The amnion can be further divided into amnion epithelium, which is this layer on top, and the amnion mesenchyme. Decidual capsularis is where you see in the fetal membrane. And in this, you will see some maternal blood vessels such as this. The reason I'm showing this slide is because just wants to let people know that we can actually assess the maternal blood vessel in the fetal membrane itself. We don't, and on top of that, we can also assess the decidual basalis on the maternal surface for maternal blood vessels. And in this case, the maternal vessel in the decidual capsularis basically unremarkable here. Okay, next let's look at the cross sections, the full thickness of the placenta parenchyma. As you can see here, this is a 32 weeks gestations, which means that this in between second to third trimesters, and the chorionic villi at that stage shouldn't be this small. Chorionic villi this small would be around somewhere near term to term for such a small and irregular shape villi. So in this case, we call this as accelerated villus maturation. Here is a higher magnifications to show you a closer view of the chorionic villi, which is very small and shouldn't be at this stage at 32 weeks. And this arrow is implying the syncytial knots, which is a multinucleated cell, or sometimes we call it as syncytial trophoblast. Usually in the hypertensions, we can see a slight increase in the syncytial knots formation. And when it is increased in a hypertensive case, we call it as Taney-Parker change. And roughly the percentage between the syncytial knots to chorionic villi is about 20 to 40%, and that depends on the various gestational age. So at term, it is roughly around 30%, which means that you should be able to see about 3 syncytial knots for every 10 chorionic villi. So in this case, it wasn't increased, so it was roughly around that particular range. The only thing is accelerated villus maturation. The next most significant things that we saw, so this is a section taken from the maternal surface, and what you see over here is actually decidua basalis, and this very pinkish thing here, rounded with the lumen in the center, are basically maternal blood vessels. And the maternal blood vessels wall is very much thickened, as you can see here. And why is it so? It's because it has been replaced by fibrinoid necrosis. So this eosinophilic material here are basically fibrinoid necrosis. So the maternal blood vessel wall are surrounded with fibrinoid necrosis in these vessels, as well as in this one and this one. And if you look closer, you'll be able to see some foam cells as well within the wall of the blood vessels. And fibrinoid necrosis and foam cells are two features that is characteristic of what we call as acute arteriosis in maternal blood vessels. And we see this in hypertensive cases, preeclampsia cases. A close-up view for the foam cells that I mentioned just now. So this is the foam cells with abundant vacuolated cytoplasms and a smaller nuclei. And this is the fibrinoid necrosis over here. Interestingly, in the fetal membrane, we also see some pigments. So when we see pigments, it implies two possibilities. One is a possible meconium pigments macrophages within the fetal membrane, and that occurs when there is fetus passing out meconium, and that occurs usually in term delivery, and in this case it's 32, so it's very unlikely to be meconium. And also meconium, if it comes, it should be from the amniotic cavity, which is over here. Then you have the amnion epithelium, amnion mesenchyme, the chorion. So the pigment should start from here, and eventually it may goes up to the level of the decidual capsularis, which may take some time. And you should be able to see some over here as well. So we don't see any over here. So this is likely to be hemosiderin. Hemosiderin implies that could be some hemorrhage previously. So, and the red blood cell has been maybe engulfed by macrophages already, and what is left behind is hemosiderin. We can actually prove this by performing Pearl stain. However, we did not prove because it's not really so significantly to know that. So all in all, the placenta is having features of consistent with maternal vascular malperfusion. We will talk a little bit more about that later, with accelerated venous maturations, acute arteriosis of the maternal blood vessels with fibrinoid necrosis and foam cells, negative for Taney-Parker changes, negative for distal venous hypoplasia, negative for acute inflammations, negative for massive perivenous fibrin depositions, and this is also known as maternal floor infarctions, negative for extensive decidual infarction. This is one feature that you see actually in APLS. We didn't see maternal vascular thrombosis, which is one of the things that I might suspected in APLS. Did not see intervenous thrombosis. There's no chronic velitis, no chronic histiocytic intervenositis. So just a little bit about what is the histological characteristic of maternal vascular malperfusion. So mainly there are 3 or 4 features. Number 1 is accelerated venous maturation. Number 2 is distal venous hypoplasia. Both of these falls under the category of altered venous morphology. And we have increased syncytial knots formations, which I mentioned just now, also known as Taney-Parker change. And lastly, we have decidual arteriopathy, which is the acute arteriosis, mural thrombus, mural hypertrophy, and retention of the smooth muscle in the maternal blood vessels. I'll explain a little bit more on each of them. So when we say accelerated venous maturation, it means that the villus are very small, thin, elongated with increased syncytial knots. So we see all these small elongated villi, although the syncytial knot was not increased. And you have to actually establish this by looking at the maternal surface side of the parenchyma and not the fetal side. Distal venous hypoplasia is paucity of the villi in relation to the surrounding stem villi. So what we will see is that the villi are all very far spread apart. I'll show you a picture of this. So this is accelerated venous maturation. It looks a little bit like what we see just now, very small chronic villi, irregular in shape. And here you see all the villi are very far apart, and you see only the stem vessels that is in between them. So this is distal venous hypoplasia. How about Taney-Parker change? This I have mentioned a little bit already. Basically, it's increased nuclear clumping and basophilia. So it becomes more darkly stained, and syncytial trophoblasts or syncytial knots are actually multinucleated cells. And as I said, the number change based on the gestational age, and roughly is around about 20 to 40%. And the rest I've mentioned already. So you can see here, this is the syncytial knots or syncytial trophoblasts. They are multinucleated cells, and they are very easily identified. Some of them may be still attached to the chronic villi, some detach into the space in between, intervillous space. And if you count the number of syncytial knots against the chronic villi, this will definitely be more than 1 to 1. So definitely 100%. The normal range, as I said earlier, is 20 to 40%. Decidual arteriopathy, basically 2 main types. Acute arteriosis is what we've seen just now, with fibrinoid necrosis of the vessel wall with and without foam cells. Whereas mural hypertrophy or retention of the smooth muscle, this is characterized by a maternal vessel with thickened wall measuring more than 1/3 of the mean circumference of the vessels. And you can actually see smooth muscles within the wall. So basically the remodeling of the maternal blood vessels has been compromised. So again, this is the fibrinoid necrosis of the maternal blood vessels here as well. This one to show you that there can be a lot of foam cells within the acute arteriosis. This is, we can either call it as mural hypertrophy or retention of the smooth muscles. So what is the cause of maternal vascular malperfusion? You can have maternal vascular disease, diabetes, chronic hypertension, thrombophilia, smoking, drug abuse, and a prior history of pregnancy with intrauterine growth rate retardations or fetal growth rate restrictions. Just a little bit about APLS. Is there any specific histological features? So these are some of the publications on APLS on placenta histological changes. And these two, the conclusion is that there is no specific histological placenta changes. Both of them mentioned that. And but they say what could be seen is uteroplacental vasculopathy, such as placental infarctions and preeclampsia-related changes. And for this, it says decidual infarctions, intravascular fibrin deposition, syncytial knots formations, and fibrosis. So basically, not very specific related changes. This is a systematic reviews on APLS, on placenta changes, and they concluded that placenta infarctions impair spiral artery remodeling, which is the arteriopathy sorts of changes, decidual inflammations, increased syncytial knots, decreased vascular syncytial membrane, and depositions of complement split products, C4D. So they say this is the changes that is commonly seen among all publications. I think that's all from me. Thank you very much.
Thank you very much, Prof. Tan. So we are going to invite Dr. Izyan to talk about this case in the obstetric point of view, and followed by summing up the case.
All right, thank you very much, Prof. Lim, and I'm very honored to have Professor Tan and also Dr. Prof. Shahrir to contribute to this case, because it's very difficult for us to manage in the subsequent pregnancy. So my talk is going to be about preeclampsia and to the clinical question that was posed in the CPC. Is this a preventable disease? So if the patient had a severe preeclampsia in the first pregnancy, is subsequent pregnancy going to be affected similarly? And also we are going to have IUGR and also severe preeclampsia very early before the fetus reach maturity. So this is my topic today. So I would just like to use this algorithm on the current recommended practice to screen for preeclampsia and possibly to prevent preeclampsia. So I divided into 5 different checkpoints. So the first one is at booking. So there are maternal risk factors that can predict development of preeclampsia. For example, in a primary gravida or having a new partner or last childbirth more than 10 years seems to reset the placenta, the memory to be like a primary gravida. For this patient, the first pregnancy that was affected is a primary gravida. So she did not have any other risk factors, and the SLE, the antiphospholipid syndrome is also presumed because of the first pregnancy was affected so severely and very early. So there are other risk factors such as twin pregnancy, advanced maternal age. But for this patient, she already have 2 risk factors, which are major criteria for developing preeclampsia. So with this booking, we can combine with the first trimester screening, whereby we can do mean arterial blood pressure and also look at the uterine artery pulsatility index to see how good is the placenta differentiation. And there is also a recent biomarker that can be done, which is the serum placenta growth factor. This marker has a good predictive value in determining which patient actually develop preeclampsia and which does not. Okay, so and also the second trimester to trimester and term, we will go as we go on. So with this first trimester screening, once we identify the patient is at high risk, we can give aspirin, which is an antiplatelet. And also high dose calcium. I also talked about how these 2 main treatment can actually prevent preeclampsia. And also we are talking about the second trimester screening using the uterine artery Doppler waveform. How good is it in terms of diagnosing which patient would develop a preeclampsia? And also third trimester and at term. So whereby the only prevention mechanism is actually delivery before the onset of preeclampsia. There is the delivery is the only cure for preeclampsia because we need to get the placenta out. So just a little bit overview of preeclampsia. So what is preeclampsia actually? Preeclampsia is basically a disease specific in pregnancy, is described or defined as a new onset of hypertension after 20 weeks, which is associated with significant proteinuria, signifying permeability or damage at the microvascular level, and also a fetal growth restriction and or other endothelial dysfunction such as renal, hematological, or hepatic impairment. So this definition, if you just memorize it, you will not understand the disease itself. But what we need to understand, why is it defined as that, is because of the pathophysiology of preeclampsia. So preeclampsia is actually a disease of defective placentation. It is a two-stage disease whereby there is a first step of defective placentation whereby the placenta is poorly formed, and then triggering the release of these vasoactive markers, which is the SPID1 or the vascular endothelial growth factor. And these markers are actually a sign that the placenta is trying to give a signal to the mother that they are malformation and the baby is not getting enough supply. So these are like a mechanism that the placenta is trying to get more blood flow to the baby. So by doing so, all these vasoactive markers then trigger changes into the maternal circulation, leading on to the classic symptoms and signs of preeclampsia, which is the stage 2. So as I mentioned earlier, what is the defective implantation? Basically, it's this formation. There's this in a non-pregnant women, there's spiral arterioles that spans from the maternal vessel to the endometrium. So in pregnancy, usually these spiral arterioles will need to be converted into a low resistance and high flow to be able to supply the baby, and the placenta is converted into a high flow, good volume to the baby. However, in preeclampsia, there is a defective trophoblastic implantation whereby the spiral arteriole remains to be a high resistance and a low flow vessel and provide very little blood flow to the baby. And that's why we have a fetal manifestation of the intrauterine growth restriction, a chronic hypoxia that occurs a long time throughout the pregnancy. And when this happens, usually the maternal manifestation, because of these vasoactive materials, they will develop hypertension because the placenta is trying to give signal to the mother that they want more blood. So another mechanism to give more blood is to increase the blood pressure of the mother so that they'll be able to supply more blood flow to the baby. So in effect, these vasoactive markers also give do damage to the maternal endothelial system, whereby there is liver problem, kidneys, and also proteinuria because of the permeability of the vascular vessel, and also in some cases activation of the coagulation as a secondary to the defective trophoblastic implantation, and also secondary to the release of these vasoactive markers. So as mentioned earlier, preeclampsia has the placenta as the central role. The culprit is actually a defective placentation. So because of this abnormal placentation, so they will develop underperfusion at the placenta level, release of the vasoactive material by the placenta, and also this chronic hypoxia then develop into preeclampsia. So for this patient, actually she developed early onset preeclampsia because she developed it at 29 to 31 weeks. So this early onset is defined as a diagnosis before 32 weeks. And usually these are the patients that have the classical preeclampsia, a primary gravida with a abnormal placenta, and because of the failure of the spiral arteries conversion. However, we do see late onset preeclampsia, which is usually occurs near term. For example, patients who are already having multiple risk factors would still be treated with aspirin, but still develop preeclampsia, but later on at term or late onset preeclampsia. And these are the patients who are non-classical. Usually they are multigravida with chronic hypertension or uncontrolled GDM that would then develop into preeclampsia. So the hypothesis of this is rather the placenta is maybe formed at the first level. However, towards term, there is a hypoxia caused by the placenta is being limited to supply the baby. So the outgrowth of blood supply towards term also give rise to underperfusion, release of the vasoactive materials, chronic hypoxia, and then develop preeclampsia. However, there's the pathophysiology of late onset preeclampsia is still not well defined compared to the early onset preeclampsia. Hence, the treatment is very difficult to treat to prevent. So going back to this preeclampsia screening and prevention, so as we know, any patient with high risk of preeclampsia would then be treated with a prophylaxis of low dose aspirin, and studies have shown that you need to have a certain dose and also started by a certain week. So for this purpose, the aspirin trial has given the dose to be between 80 to 150 milligram daily and need to be started before 16 weeks to be able to be effective, because 16 week is the second wave trophoblast differentiation, and that is where you need to get the aspirin to prevent the thrombosis and also the placenta malformation. And high dose calcium, we will talk about how does calcium prevent preeclampsia. Okay, so I'll talk about aspirin first. So how does aspirin reduce early onset preeclampsia? So aspirin trial, which is this study, a multi-center study done in United Kingdom, it actually a very large study that actually look at how does aspirin prevent preeclampsia, or how good is aspirin in preventing preeclampsia. So the mechanism that is postulated is because aspirin, we all know it is a COX inhibitor, and COX is responsible for the production of prostaglandin. And prostaglandin, the small molecules that actually do the housekeeping function, for example, platelet activation, aggregation, inflammation, and also endothelium vasoconstriction and vascular injury. So having too much of prostaglandin is also not good because it will give rise to many problems. So having aspirin actually block this arachidonic acid into prostaglandin H2, and thus preventing the production of all these thromboxane A2, prostacyclin, and all these prevent the sequelae of platelet activation and also endothelium injury. So aspirin actually improves placentation when given in before 16 weeks, and actually inhibit thrombosis in the placenta, and also being an anti-inflammatory, it actually stabilizes the endothelium to prevent the development of preeclampsia later on, because we are acting at the placenta level. Okay, however, it has been shown that it does not reduce the late onset preeclampsia, because the late onset preeclampsia is, as hypothesized, is not due to the platelet, due to the placenta being malformation, but rather an outgrowth of blood supply towards them. So still, even with aspirin, the patient at risk of preeclampsia may still develop preeclampsia, but late onset, whereby delivery is can cure the disease, and it's not bad because we can deliver the baby in a mature condition, and usually the preeclampsia is less severe compared to the early onset preeclampsia. Moving on to calcium. So why does calcium? Because we know that calcium is important for smooth muscle contraction. Then why do we give exogenous calcium? It seems like it's contradicting. But it has been shown that pregnancy, because it's a state of high calcium demand, about 30% of calcium intake goes to the growing fetus for development of the skeletal system, the bones. So some patients during pregnancy, they are at risk of calcium deficiency. So exogenous calcium actually inhibit this parathyroid gland activity, whereby this parathyroid then cause increase in the blood calcium. So when we give exogenous high dose calcium, it actually inhibits parathyroid gland activity by a negative feedback mechanism, and that actually reduce intracellular calcium and then reduce the smooth muscle contractility. And these are beneficial in reducing hypertensive disease such as preeclampsia, and also preterm labor because of the smooth muscle relaxation that happen. And calcium is also being postulated as having anti-inflammatory effect, and because of the increased nitric oxide pathway, and also prevent endothelial activation. So in RCT, there's mixed results, some saying that calcium is only mildly or to moderately effective to prevent preeclampsia, but others have shown has a 55% reduction. And also there's a disparity regarding how much calcium a woman should take, between 1 gram to 2 gram, or is it 500 milligram is enough. So the evidence regarding calcium is much less compared to aspirin. However, it has been shown that if given a high dose after 20 weeks has been beneficial to prevent preeclampsia. So going back to this Bayes theorem of preeclampsia risk. So this theory is again to show that for every pregnant woman with a placenta in situ, there is a risk of preeclampsia, whether it's a low risk or high risk. So some patients, when there are multiple risk factors, so they are deemed at high risk, what happens is that this mean age at which they develop preeclampsia is actually shifted to the left, and thereby you can see here these are the weeks from 24 to 80 weeks of pregnancy, and pregnancy only happen until 42 weeks. The normal pregnancy only until 42 weeks. So when the patient is at low risk, so the mean age is actually between 52 or 54 weeks, whereby the majority of women are already delivered by that time. So in a low risk patient, for example, Paris women without preeclampsia and also tall women, so they have a low risk, and only 2 to 3% will actually develop preeclampsia. However, in a patient with a high risk with chronic hypertension, autoimmune disease, and also advanced age and obese, whereby it was given here every 10 kilo, more than 70 kilo, you increase your risk of preeclampsia, and as obesity is always associated with preeclampsia. You can see the shifted curve whereby at least 30% will fall under the area under the curve, and this 30% is the one who will develop early onset preeclampsia and also severe preeclampsia. So this is the Bayes theorem of preeclampsia risk, whereby this is the reason why some patients develop early onset and some patients actually do not develop preeclampsia at all in their pregnancy history. So another method of prevention is to deliver before the preeclampsia develop, and that is why usually majority of pregnancy are not affected because they deliver before the onset of preeclampsia. But some pregnancies are actually complicated and actually develop preeclampsia every time if they are not started on aspirin. So by giving aspirin, it actually reduce or inhibit or prevent preeclampsia by 60%, at least the early onset and also the preterm preeclampsia before 37 weeks. So this is quite good. A 60% reduction is actually quite good. From 30%, maybe we are down to 10 to 15%, which is quite good. And with that, we reduce the amount of preterm delivery, iatrogenic preterm delivery that has to be done because of the severe preeclampsia. So that reduce the preterm delivery, reduce the complications associated with prematurity, such as the intravascular hemorrhage, the cerebral palsy, which is associated with the affected neurodevelopmental prematurity. Okay, so what about this uterine artery Doppler? So I'll just go back to this screening algorithm. So let's say you've identified a patient and you've put them on low dose aspirin and high dose calcium. What is the role of this second trimester screening, the uterine artery Doppler waveform? So because you already, let's say the patient is not deemed at high risk. However, during the second trimester, when we do the uterine artery Doppler, then we found out that the patient is actually having high risk of preeclampsia. But we are already past the point of giving aspirin. We can maybe give high dose calcium that can prevent a little bit of preeclampsia. But this uterine artery Doppler, okay, so it's actually signifying what is the vascular flow, or what is the uteroplacental circulation. So having a notching at the uterine artery actually signifies that there is high resistance uteroplacental circulation and also associated with poor flow, because usually in a normal pregnancy the flow is persistent. All right, during asystole there will be an increased flow. However, during the diastole the flow is still consistent and remains the same. But in a dipping or in a notching diastolic flow, that means there is a reduced flow and also there is a high resistance. So this is characteristic of what Prof. Tan was mentioning about the placenta microvasculopathy. So this is what happened. So when we identified this patient, actually it has a high predictive value for development of preeclampsia and or intrauterine growth restriction. However, in a low population, it's actually not useful because we are going to be causing anxiety to the women. So it's only useful for patients who are at high risk, and for us to decide which patient that will actually require an increased surveillance in monitoring, because they might have an early onset preeclampsia even in that asymptomatic period. So if they are not being monitored for their blood pressure and their fetal growth, they may not know that they actually have preeclampsia because they can be asymptomatic until a late stage. So this is useful for screening only in a high risk pregnancy. It has a low sensitivity but a very high specificity, 40% sensitivity but 90% specificity. However, there's also disparity regarding which indexes we use. So whether a paucity index of more than 95th centile or whether there's a presence of notching is characteristic of this uterine artery Doppler being positive for screening. So I just would like to show that for this patient, I actually used this calculator provided by the Fetal Medicine Foundation. It actually combines the maternal characteristics, the uterine artery Doppler, and also the mean arterial pressure, and if we have the serum LGF. So for this patient, I've inserted that all her age, she's advanced age, she's also a short stature, 145 centimeter, but she's not obese, and she has a history of preeclampsia, and also at the moment she was because of the antiphospholipid syndrome was not diagnosed. It's only a possibility, so it's no. So based on her maternal risk factors alone, her risk to get preeclampsia less than 32 weeks, which is the early onset, is very high. It's 1 in 34, which is 30%. And also towards 36 weeks is very high. It's about 1 in 10. Okay, so but when I put in the uterine artery Doppler waveform and also the pulsatility index and also the mean arterial pressure, so at the moment she is still normotensive, and the uterine artery pulsatility index is actually 0.8, which is still normal, even though there is a notching, but it's still within the normal range. So then her risk of developing preeclampsia is actually very low because of this combination of maternal risk and also the uterine artery Doppler. So this actually explain why this patient is still having having been spared from the preeclampsia, because although the first pregnancy was not on aspirin, she developed a full-blown preeclampsia very early on. This pregnancy, she benefited from aspirin from 8 weeks onwards, and she is compliant, and we have been monitoring her blood pressure and her fetal growth. Everything is normal as of now at 32 weeks. So hopefully for this patient, even though there is a seronegative Apls, but is a disease that can be prevented with aspirin alone. So hopefully I can bring this patient to as near term as possible, hopefully at 37 to 38 weeks. And with that, because of the Bayes theorem, I may not need to I may not need to do a iatrogenic preterm delivery. However, to go until post-state may not be a good idea because she may eventually develop preeclampsia just because of the high risk of the Bayes theorem just now. So with that, I think the conclusion is that preeclampsia is a disorder of the placenta because of the poor trophoblastic invasion, and this actually carries a high risk of maternal and perinatal morbidity and mortality because of the preterm delivery and also the impact on the maternal vessel. It can be predicted with some accuracy using the first trimester screening algorithm, so that treatment with low dose aspirin and calcium can be targeted rather than given to everyone. Okay, so and uterine artery Doppler screening is useful in high risk population to target patients that will need increased surveillance. And so treatment with aspirin and calcium can reduce risk of preeclampsia, especially an early onset preterm disease such as in this patient. And a late onset preeclampsia is a different entity with different pathophysiology, hence no real prevention and cure except for delivery. And with that, I think we conclude this CPC. I think I leave to the moderator and also for Kahoot after one. Thank you very much.
Thank you, Dr. Izyan, for summing up the whole obstetric, how we manage and how we try our best to prevent preeclampsia and IUGR in obstetric cases. I think with the interest of time, probably we are going to take only one question. Is serum PIGF at first trimester routinely done in our center for patients with suspected high risk of preeclampsia? Probably to Dr. Izyan.
Thank you very much for the question. Actually, it's not routinely done at our center because it's still an expensive test and not offered by our laboratory. But we do have efforts from Roche, which is one of the companies, to incorporate this into our first trimester screening. So the answer is no, not routinely used, but in some patients we can send outside to do the serum PLGF.
Right, thank you, Dr. Izyan. So this case illustrated how difficult for us to actually find out the reason why certain women having preeclampsia in a very early gestation, and despite the difficulty in diagnosing whether this patient is having antiphospholipid syndrome or not, and Prof. Tan also showing us there is really no specific placenta changes to help us in diagnosing, but we do see some placenta changes in patients with hypertensive disorder, preeclampsia and IUGR. So with the help of placenta HPE and the clinical history, we really need to identify this patient as early as possible, educate the patient so that they can come to see us as early as possible when they are pregnant, so that we can actually, even though let's say we can't totally prevent preeclampsia or IUGR, at least, yeah, we hope with the use of aspirin, with the use of calcium started as early as possible, with the possibility of certain screening like uterine artery Doppler, we can predict, yeah, how much how high risk is this patient can go into preeclampsia and IUGR, so that they can be referred to tertiary center and we can vigilantly monitor them, and hopefully they can have a better outcome as compared to their previous pregnancy. So with that, I thank all our speakers, and I'll pass that back to our technical support in progressing to the Kahoot for the students. Thank you very much.
Thank you.